Thanks for the nice introduction. I understand I'm standing between you and lunch, which is never a good thing. And it certainly is humbling to be here, following both Dr. Travis and Bruce Spies. Bruce I've known for many years. And Bruce and I agree, I think, on 99.99% things with regards to blood management, blood conservation, et cetera. The only place we differ, I don't know whether Bruce just stepped out, is Bruce for years is very passionate, very knowledgeable about it, but Bruce's contention is you need to be a zealot to drive change. My contention is you need to be an evangelist, and there's a difference between being an evangelist and a zealot, but maybe we can get that in the before and after discussion. I am an anesthesiologist, as is Bruce. We don't certainly lay claim to blood conservation, blood management. I think we, like perfusionists, are the connectors in the operating room and beyond, in that we deal with a lot of different types of surgeons, different physicians, nurses, nurse practitioners. And so I think we have the ability as sort of agents of change to help drive this. And so that's one of the reasons I think you see a lot of anesthesiologists and perfusionists driving blood management forward. My talk today specifically is about more red cell therapy than, as I call it, the yellow stuff that Bruce talked about. Both are equally important. I'm not surprised at all, having heard Bruce speak a number of times, that there's a lot of meshing between his talk and my talk. And the subtext that both he and I bring to bear, and I think to some extent Dr. Travis as well, is the evidence is readily available. The evidence is readily available. It's how do we get people to pick up and use this information in a meaningful way and to do it in an enduring way. And again, as Bruce said, this is largely a cultural process. Whereas Bruce is extraordinarily knowledgeable in basic science, what I've spent the better part of 15 years on is working on implementation science. How exactly do we get people to get up and use this? And as it always starts, I had to change my own practice first back in the Navy Hospital in San Diego back in the mid-1990s. Some of you may know or remember Dr. Paul Potter, who was an early adapter of this. He was my early mentor, and John Waters, who spoke the other day as well. So I changed my practice, and then the anesthesia department practice, then the surgery department practice at the Navy Hospital in San Diego. Moved to St. Vincent as a reservist at 900-bed hospital in Indianapolis, changed hospital-wide practice, so not just surgical, but also medical, inpatient, and outpatient, and ultimately worked with about 120 or 130 hospitals across the United States, doing system-wide practice for Advocate Healthcare, St. Joseph Healthcare, McLaren Healthcare, and several large academic systems as well. But again, today what I'm going to talk about and get you to lunch is red cell therapy, but under the sort of greater banner of how do we drive change, why do we need to drive change, what's the messaging we need to use for physicians as well as other professionals such as PAs, nurse practitioners, to use the best available information as a team-based approach to blood conservation and blood management. So am I not doing this? Oops, no disclosures whatsoever. Am I using the right button or the left button? Okay, so this is probably a good place to start, maybe wake you up a little bit. Believe it or not, most of us are probably not old enough to remember this. I can kind of remember TV advertising for smoking, but it turns out that in the 40s and 50s, not only was it very, very common to use celebrities to endorse smoking, sports stars like you would see today, Jackie Robinson, movie stars like Ronald Reagan did cigarette commercials. I mean, everybody did them. But one of the particularly evil and brilliant plans that the big tobacco industry had was using physicians and dentists to endorse smoking. And so they started with saying, doctors say, hey, there's no problems with smoking. We've got 2 years of evidence that says that, there's no problem with it, that some cigarettes are easier on your throat than others. So they were using dentists to do that. But then they started to say, well, it's not just that doctors are endorsing smoking, but they're endorsing my particular product. And so probably the most successful campaign arguably was Camel Cigarettes, who was running surveys that said that most doctors prefer Camel cigarettes. Ask your doctor doctor, which cigarette you should smoke. And I've not been able to find the actual ad copy out of this, but ostensibly this campaign by Camel that said most doctors prefer, surveys show most doctors prefer Camel cigarettes, eventually led to what's almost kind of now a joke, 4 out of 5 doctors recommend, 4 out of 5 dentists recommend. So it's interesting that this concept of surveying and what is evidence-based can be traced back in some ways to the tobacco industry. So here's the gist of my talk, is why 4 out of 5 isn't good enough. Why having 4 out of 5 doctors who believe in the evidence for red cell therapy or platelet therapy or plasma therapy is simply not sufficient, particularly in this day and age where we have team-based care. And I'll give you a very, very real example of this, which interestingly ties into Dr. Travis's talk about TAVR. So this is a picture of my mother-in-law, and I actually do love my mother-in-law very much. My mother-in-law is 86 years old, God bless her, volunteers at the local hospital every week. She is 5 foot nothing, 100 pounds soaking wet, and she, just like Dr. Travis described, had sclerotic aortic stenosis, got to the point that when she would come and visit us, she's going up the stairs and she's huffing and puffing, but she's a little old lady, probably wouldn't tolerate full bypass surgery to have this done, and so was a TAVR candidate. She had it done at our heart hospital, St. Vincent Heart Hospital. We are a leader in a lot of cardiac procedures, both cardiology and cardiac surgery, so I was very comfortable with her going to see Dr. Hermiller and having a TAVR done in February. So this is my story. So, of course, one of my concern, not my only concern, was blood transfusions in her post-operatively. Again, 100 pounds soaking wet. Of course, she's got a hemoglobin of 11 on a good day because she's 86 years old and probably nutrition isn't that great. So she starts at 11-ish. Post-surgery, because these are big catheters and a little groin, she's down in kind of the low 8s. And so talk to the cardiologist, and a lot of this is prompted by them because they know I'm the blood guy, about what are we going to do about transfusion. The cardiologist, Dr. Hermiller, hey, we're not going to transfuse her. She looks great, no problem whatsoever. So that's day 0. Day number 1, post-operatively, it's a nurse practitioner who comes in, looks at her number. She's now sagged at around 7, 8 or so, but stable, looking good, no problem. She didn't really have any coronary disease. This was a valvular disease. Nurse practitioner, we're not going to transfuse her. Day number 2, post-operatively, this is now one of the cardiac surgeons, a cross-covering partner for the cardiac surgeon that was on call, who sees the patient. Also, hey, I'm all in. She's 7, 8-ish. We're not going to transfuse her. I suggested about giving her IV iron. He agreed that was a good idea. Part of the reason is IV iron certainly is a lot more easier way to get patients to recover their iron stores, which she was low coming in, I'm sure. Oops. Gosh, sorry. Water on the deck. My mother-in-law, like a lot of 86-year-old ladies, her day revolves around whether she's going to have a bowel movement or not. And don't tell her I said this, but giving her oral iron was never going to work because she would never take it because she was going to get bound up. So IV iron is a much, much better choice for her. And one of the things that I always mention is iron stores actually correlate better with rehab potential and vigor than does hemoglobin. And so the cardiac surgeon also was very, very happy to write for IV iron. So we're good to go. So, we're not going to transfuse, she's IV iron. Post-op day number 3, it's yet another different nurse practitioner that rounds. This is now, I think, Sunday. And again, also fine with a, 7, 8, 8-ish sort of a hemoglobin. We're good to go. But on day number, post-op day 4, which really is the 5th episode, this is the one day I'm not there for rounds, but my wife is. And again, as you may know, if your mom or dad's in the hospital, you're going to be there every single minute, which is a testament to patient safety. We want to make sure everything goes right. So the PA, which nobody had ever seen before, and it's now the 5th person looking at her numbers, basically the same number, he walks in and announces, well, we're going to give you a couple units of blood. To which my mother-in-law said, oh, okay, because this guy walks in with a white coat and he, needs a couple units of blood. My wife was there and said, well, why is she getting blood? Well, her hemoglobin's low, and so she needs blood. Well, what is it? Well, it's, 7, 8, 7, 7, whatever it was. Actually, it was a little bit of a labosis. We repeated it and it was 8, 1. But anyway, so basically the first response is you're getting blood. When my wife questioned this, what he said is, well, if this was my mom, she's looking pale, she's looking anemic, she needs some blood, I would just give her the blood. at which point my wife says, well, no, we really don't want to do that, and we want to know what's going on. His third response is, well, she's going to get it anyway, because when she goes home, she's going to see her doctor, and they're going to think she needs blood, so she's just going to get it anyway, so why not just give it to her here? And this is this is a true story. This is exactly what happened at my hospital, where we've been preaching blood management for 15 years. At which point my wife then got pissed, picked up the phone and called me. And, of course, she's not pissed at the PA. She's pissed at me because I'm not there. And I said, just, give me the phone. And I just told him, look, she's not getting blood. It's our right to refuse it. We're going to call the attending and talk to them. And so, sure enough, we called the attending. The attending said, no, we don't want to get her blood. She's going home today. She's fine. But this is what I want to stress to you in a real-world example. This is exactly what happens in medical and surgical patients, not just cardiac surgery patients, all over the country, if not all over the globe. This is team-based care. So 4 out of 5 physicians or nurse practitioners or PAs that agree with using the best available evidence is not enough. We really need to be a 5 out of 5 system. And again, it's interesting to hear Bruce talk about, this is the way forward. My approach to blood management, blood conservation, really has evolved to being a safety issue, transfusion safety. This is about high reliability. Every single time, every single patient, right product, right patient, right dose, right time. And I'm just giving you a real-world example of what happens. I think a testament to this is the STS is a wonderful organization, has put themselves on notice in terms of their measuring transfusion outcomes, measuring transfusion percentages. But one of the things they did early on is split transfusions into intraoperative and postoperative buckets. And the reason they did that, at least my perception of that, is they said, look, we'll do what we can on our watch in our operating room with our perfusionists and our cardiac surgeons and our cardiac anesthesiologists, but we can't control what happens with the hospitalist or the intensivist. And what I would tell you is I did for my father a year ago who had a GI bleed, and my mother-in-law, not on my watch. Every single time, every single patient, every single touch, we need to get this right, whether it's red cells, plasma, platelets, or cryoprecipitate. So that's kind of my overarching approach here. This is where we need to be, a high reliability organization where all providers, again, these days it's not just physicians, all providers have to be up to speed on what is the best available evidence. So what I'll go through relatively quickly is, at least as Bruce did, what is the current evidence for red cell transfusion therapy. Bruce covered nicely, as I said, the yellow stuff. Both are equally important, and this takes nothing away from what you do and have done for many, many years, which is blood conservation, which is preoperative preparation, cell recycling, shorter perfusion circuits, coded circuits, point-of-care testing, etc. And I can only get away with saying this here, that sexy stuff, blood conservation, sexy stuff, is absolutely critically important, but it is not less important than having evidence-based transfusion decisions. They, in fact, have to be done in conjunction, because with the stroke of a pen, or these days the click of a mouse, whatever you do in the operating room can be completely undone by someone who is just basically doing what we call a drive-by transfusion. So the vexing question, I think, now for almost 17 years is the anemia versus transfusion issue. And legitimately, we have all been told that anemia is not good for our patients and should be avoided. And there are a variety of studies that say, whether they're correlation or causation, that show patients who are preoperatively, intraoperatively, or postoperatively anemic don't do as well as patients who are not anemic. The problem is, the logical assumption has been, is if my patient is anemic and that's not good, if I transfuse them so they're no longer anemic, that must be good, that must be better. But again, I'll show you the evidence that says that that's not necessarily true. So the first study to really look at the effectiveness of transfusions, do transfusions make anemic patients better, was published actually 17 years ago in February, and it was called the TRICK trial. I mention it only because of sort of historical purposes, but it was really the turning point, the first shot across the bow that said that although patients are anemic, perhaps transfusions aren't the cat's pajamas. So this was a Canadian study, a prospective randomized trial of over 800 patients who were very sick in the ICUs that were randomized to one of two transfusion strategies, either transfuse the traditional approach to old sick patients back in the 1990s in the way that Bruce and I were trained, transfuse at hemoglobin of 10, or a very radical departure for the time, which was a conservative approach, which was transfuse these patients at a hemoglobin of 7. The backstory about the study is that many physicians were very reticent to enroll their patients because they were concerned that withdrawing transfusions for patients was unethical, can actually cause harm. It turned out the study showed, and many of you are familiar with this, it actually showed that the patients did better being transfused more conservatively, worse being transfused more liberally. And again, that was at least the beginning of a game-changing sort of approach, that although we assumed that old sick patients needed more blood, this was the first of now 20-plus studies that show that patients don't do better being transfused more liberally. In fact, that less is more. Being transfused more restrictively, in fact, at least is as good, if not better. This particular study, I like to point out, is ranked in the literature as the #1 study that has changed transfusion practice worldwide. I would tell you even today that we're not at a majority yet of physicians, nurse practitioners, and PAs who practiced 17 years after the publication of this study are familiar with the implications of this study, more conservative transfusion practice being at least as effective, or the other studies that have been published since that time. The Institute of Medicine has said in the past that it takes, on average, 17 years for physicians to integrate peer-reviewed information into clinical practice. This is actually part of the evidence that I would present there. 17 years after the TRIC trial, we do not have 5 out of 5 physicians that are doing it, whether we're at 3 out of 5 or 4 out of 5, or, it doesn't really matter. We need to get to 5 out of 5. So the first trial was an adult study called the TRIC trial, published in 1999. I'll quickly go through the other studies just to show you that we've looked at a variety of patient populations. We actually put out our transfusion guidelines at St. Vincent, Indianapolis in 2001 with only the TRIC trial to kind of lay out there, and we had a transfusion guidance of 7 for most patients, 8 for active cardiac disease. And one of the logical things we got pushback was, well, not on my watch. So great, if the crazy critical care doctors want to do this, that's fine. But what about our cardiac surgery patients? What about our cardiology patients, et cetera? So I'll walk through those studies quickly. Published in 2006 was a pediatric neonatal study looking at a conservative versus liberal transfusion therapy called the PINT trial. That study showed that the conservative arm was at least as effective in terms of transfusion practice and more liberal transfusion therapy with less transfusion exposure. In 2007 was the TRIP ICU study, which was a pediatric ICU study, very similar to the adult ICU study, again showing no significant difference in outcomes between either group, with about a 40% reduction in transfusion exposure. The first of now 2 cardiac surgery trials was published in 2010 called the TRAX trial out of Brazil, prospective randomized of transfusion strategies in the perioperative period for cardiac surgery patients. This one chose a hemoglobin level of 10 versus 8, and kind of like the age of blood studies that I'll talk about just a little bit more. One of the problems with transfusion trials is there is no governing body that says let's do all these exactly the same. So you'll see there is some variation between the liberal and the conservative arms, which causes some confusion, particularly for those people who don't want to change, because they'll point out subtle differences as well. This was a 10 versus 8 study. Again, no difference in outcomes between the two groups, whether they're transfused liberally or conservatively, with about a 40% reduction in transfusion exposure. And a recurring theme of all these studies that I think is a recurring theme of medicine today is if we can give the same outcomes with using less of an expensive and potentially risky therapy, whether it's blood transfusion therapy or it's antibiotics or it's x-rays, that is the preferred course of action. Even equal outcomes with less exposure is the preferred course of therapy. One study that I'll talk about a little bit, this is a little bit out of your purview, but I think it's an important study, at least to me as an anesthesiologist, was called the FOCUS trial. The FOCUS trial was a prospective randomized trial of elderly hip fracture patients with cardiovascular disease having surgery. This was an important patient study for me because we have a lot of orthopedic surgeons at St. Vincent Hospital, and they were very interested in this study. The other thing is that I will tell you is this is one of the toughest patients that I manage as an anesthesiologist. These weren't patients coming in for a hip replacement surgery because they're tuned up as well as they're going to get. These are little old ladies and little old guys coming in with a hip fracture, which is a major trauma, 2 to 3 units of blood loss, not tuned up and coming in for surgery. So a very, very tough patient population, if you talk about that. The second thing is they had to have known or high risk factors for cardiovascular disease, so we're really kind of cherry-picking tough patients. The only objection that I have to this study is that they said these patients were elderly. And the reason I object is that the lower age limit was age 51. At least today, I do not consider 51 to be elderly. I maybe did a couple years ago. But the oldest patient was 183, or was 103. The average age was 82. So anyway, tough patient population. What this study showed, similar to all the other studies, was there was no difference in outcomes whether these elderly patients were transfused at 10 versus 8. And importantly, very importantly, no difference in rehab potential either. Because what our orthopedic surgeons, who are very bright guys and gals, would say is, it's great if my patient doesn't have a stroke or doesn't have a heart attack and doesn't shrivel up and die, but if they can't get out of bed in rehab, it doesn't work. And what this study showed is being transfused conservatively also did not impact their rehab potential, which is, again, very, very important. There are a growing number of consensus guidelines that have looked at this data to say, what is the right thing to do. One published back in 2011 was by the AABB that said, looked at that time 19 randomized controlled trials for red cell therapy. Their overall conclusion is that a conservative approach to transfusion practice, transfusing in the 7 to 8 range, was the highest level of evidence and should be strongly recommended. And I put this out here again when I'm talking to physicians to say this isn't Tim Hannon's personal opinion. This isn't based upon one kind of oddball study. There is a large and growing body of evidence that supports more conservative transfusion practice for all the reasons that have been talked about during this entire conference as well. GI bleed study, again, I know you don't get involved in GI bleed patients, but I think it's another important patient or population to talk about. We're getting a lot more GI bleed patients these days because of things like dabigatran, things like rivaroxaban, apixaban, all these drugs that we can't pronounce and we have a hard time treating because of a lack of reversal agents as well. So we're seeing more GI bleed these days, so it's an important study. This study was also a prospective randomized trial of upper GI bleed patients, which was excluded during the TRIC trial because they were really looking at stable ICU patients, looking at 2 different transfusion strategies, very aggressive protocol 7 versus 9. What this particular study showed was not only equivalent outcomes, but superior outcomes in GI bleed patients being transfused 7 versus 9, which is fairly, it's very significant. And not only did they get less transfusion exposure, there was about a 45% lower mortality rate in the patients transfused more conservatively, lower rebleeding rates, lower emergency surgery rates, and lower overall adverse outcomes out to 45 days. So a very, very significant study for patients with upper GI bleed. And now I'm going to go back to my 4 out of 5 doctors statement and say this. This is an all or none protocol. This protocol, which can save lives, in fact, if you look at a number needed to treat, because there is a 4% difference in mortality rate between whether you're transfused liberally or conservatively, what that means is for every 25 patients treated with this protocol versus a liberal approach, you save a life. For every 25 patients treated with conservative therapy, you save a life. The average small hospital in the United States admits anywhere between between 200 to 300 GI bleed patients. This protocol alone at a small hospital could save 8 to 12 lives a year. That's the importance of this study. But here's the 4 out of 5 doctors thing. So if the ER doctor sees the GI bleed patient and says, look, I've read the study, I'm not going to transfuse at 9 or 10, I'm good with it. They go to the ICU. The ICU doctor said, heck, we wrote the book on conservative transfusion practice. I'm certainly not going to transfuse this patient. They go to the endoscopy suite. The gastroenterologist goes, look, I'm just a scope jockey. I don't care if we transfuse this guy or not. Fine with me. Goes back to the unit. The next unit doctor says, we're good to go. The 5th doctor, who could be a cross-covering hospitalist, could be a PA, gets a phone call in the middle of the night from a nurse that says, Mrs. Jones' hemoglobin is 8.2 and says transfuse. Guess what? The benefit of the protocol disappears instantaneously with the stroke of a pen or the click of a mouse. Again, that's why I want to come back to this recurring theme. As boring as evidence-based practice may seem to be, and it's not as sexy as low-volume pump primes and all these other things, it is equally important, and in fact, it's a safety issue. We need to move to high reliability where every provider gets it right every single time, and I think this is a great illustration of that. Other studies out there. Again, another systematic review looking at these studies. And again, I'm not going into great detail. I just want you to be familiar with it's not a small amount of evidence. It is almost an overwhelming amount of evidence that supports conservative transfusion practice. This was a large meta-analysis looking at almost 20 studies at the time of transfusion practice, and it put them, interestingly, into two different buckets. When it looked at these studies, because nobody is regulating the exact numbers for the conservative versus restrictive group, it went into one bucket, which was kind of the ultra-conservative bucket, which was a hemoglobin of 7 on the lower end, and then all other studies that are mostly looking at a hemoglobin of 8 on the lower end. What they showed in this study I thought was interesting is for those studies, the 3 studies that used 7 as a lower number, these were superiority studies, meaning that all outcomes were better when they chose 7 as the number. For the other studies where they chose 8 as the lower number, they were equivalency studies, meaning it was no better or no worse. It was at least equivalent when they used a hemoglobin level of 8. So what this says is all the studies, whether they chose 7 or 8, are equally efficacious, meaning there is no harm to the patient and there's less transfusion exposure. At least in the 3 studies where they picked 7 as the number, they were superiority studies. In fact, it was better outcomes. So we're kind of left scratching our heads. Is 7 or the 8 the best number? Did the 8 numbers just pick it right the first time, or could we have gone more conservative? Again, we simply don't know at this time. Again, just some summary comments to understand, the major points here, which I think are salient, is when we look at patients for transfusing more conservatively, although I've been driving this, as Bruce said, pushing the boulder uphill for years and years and years, the number of 7 or 7 to 8 is well established in the literature. Many people say not only is this the standard of care, this should be the new norm. All the literature seems to support this particular point. And what I think is very appropriate, which, again, the print hopefully isn't too low on the lower comment, one of the most, I wouldn't say compelling, but one of the most strident arguments that I got from physicians of my age or older is we should never transfuse on a number. We shouldn't be doing cookie-cutter medicine. Guidelines are for sissies, blah, 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 all these other things. And in fact, what the literature now says is what I've supported for years. There is a number. There are numbers out there that are not just conjecture, that are based on large prospective randomized trials. We should be using numbers to transfuse, as you do in your perfusion practice as well. This is evidence-based medicine. It's not, as Bruce says, seat-of-the-pants medicine. Again, as a minor aside, you may end up taking care of some septic patients. There was one kind of open controversy that I moved from an open controversy to a closed controversy, and that was transfusing in septic patients. There was a study published in 2000 called Early Goal-Directed Sepsis. The author was a guy named Manny Rivers, and it really changed our approach to septic patients, because the management of septic patients 10, 15 years ago is when somebody came in with sepsis, and these are really, really sick patients with high mortality, was a very haphazard, very uncoordinated approach. If somebody would eventually see the patient, perhaps admit them, maybe get a consultant on board, maybe give some antibiotics, but none of it was standardized. So this study by Rivers, published in 2001, called Early Goal-Directed Sepsis, was a game changer, because it said we need to ring an alarm bell when these patients show up and have a goal-directed, standardized approach to therapy. And it saved lots and lots of lives. It is also the basis of rapid response teams, that it was so effective that we've done this as well. Well, one of the criticisms or controversies about that particular study is part of a multimodal protocol. They transfused at a hemoglobin of 10 for septic patients. And this was done before the TRIC trial, so they didn't really know about conservative protocols. And it's also important to note that they didn't transfuse all patients at a hemoglobin of 10. If patients within the first 6 hours of the protocol were not responding and their SVO2 was not coming up, then they were allowed to transfuse to a hemoglobin of 10. So it was an open question: where should we transfuse septic patients? Are the exception to the rule? Finally, it's been put to bed. There was a large prospective randomized trial called the TRIST trial, which was specifically designed to answer this question. And it showed, again, that septic patients do at least as well or better being transfused more conservatively. And for all the reasons that you may know and Bruce has talked about, blood is a very, very pro-inflammatory substance. We don't need to give septic patients more septic or more inflammatory mediators. So again, 7 is the new 10. So are there open questions? And this is really kind of the secondary gist of this talk is, are there some areas where we still don't have all the information we need? And the answer is yes. Even though we're kind of 17 years down line for the red cell trials, are there some open questions? And are there some open questions? And the answer is yes. Well, I'll talk about this one quickly because, again, this isn't necessarily your area of focus, but you know, it's funny because I again, pushed the boulder uphill for years and years and years. I think we started to hit our stride maybe 2 or 3 years ago where most people are saying, well, it's probably good to do conservative practice, but 2015 was kind of the Empire Strikes Back. There started to be some studies that pushed back and said, well, wait a minute, maybe conservative practice isn't the thing to do. And this was one of them that I was concerned about, mainly because it was published in the anesthesia literature. So this is the one and only large prospective randomized trial that said that perhaps conservative therapy isn't good for patients, and in fact it causes more harm, and it was done in surgical oncology patients. So of course I wanted to look at this and not just read the abstract. Again, a good study from the fact that it was a prospective randomized trial. It was done down in, was it in Brazil? The study was done in a different country than the United States. Not a large study, and I want to emphasize not a large study. There was 200 total patients, 100 in each group. The problem with the fact that it wasn't a large study is it was a heterogeneous group of patients. So, for example, this wasn't 200 patients with Whipple operations or 200 patients with esophagectomies or 200 patients with GI cancer. This was 200 patients, all comers with cancer. So it was a very, very mixed bag of patients. What their conclusion was is when they looked at this study, looking at 2 transfusion strategies, it was 7 versus 9, and importantly, only when they're in the ICU, not during the total conduct of care, which is the way it should be, is that the patients that were transfused liberally actually did worse. So very, very concerning, and legitimately, some anesthesiologists said, well, maybe oncology is the exception to the rule. The authors had to explain, of course, to the editors, well, why is this? Why 21 studies say conservative practice is better? Why is this different? Why are oncology patients different? And their conjecture was this. Number one, they said, well, we're using fresher blood in these particular studies, and it was leukoreduced. That was a legitimate argument with the TRIC trial published in 1999, which used non-leukoreduced blood, and they weren't looking at the age of blood. But most studies, actually, in the last 5 to 10 years, have used fresher leukoreduced blood, so not really legitimate. The second one was the main cause of death in the patients who died was sepsis. So they said, well, septic patients need more blood, but they didn't bother to read the TRIST trial that definitively said septic patients don't need more blood. And then the third explanation, which was offered by the editorialist, which was an anesthesiologist, has become known as kind of the 3 evils model, which says that anemia is evil, transfusions because they're inflammatory nature are evil. When you put them together, you get the super evil. All 3 are the worst than either one involved. And I think that's true. And I think that anemia and transfusions are both bad. That's why comprehensive blood management is so important. If we can have less anemia and less transfusions, that's the best possible outcome. Well, again, just to quickly keep moving on, my opinion, which isn't just my opinion, is this has been kind of widely attacked in the anesthesia literature. At last count, there were over 5 major universities that had written letters to the editor about this article, criticizing both its methodology as well as the conclusions. And the biggest one that I think is the most important one is because it was a small group of patients, it was heterogeneous, it was unbalanced. In the group that was conservative therapy, there were 14 more patients that were Whipples, esophagectomies, and major surgeries as well. So again, they simply weren't balanced. We had more sick patients, unfortunately, in a conservative group. And then the last piece that I think is very significant, because of protocol violations, many of the doctors who were supposed to be transfusing liberally actually transfused conservatively. The difference between the 2 groups of conservative versus liberal was almost not. It was 6.9 versus 7.9. There really wasn't much of a difference in these particular particular studies. So again, I know it sounds very, very biased, and I know you're a very friendly crowd. If I had a bunch of kind of physicians who didn't believe in conservative practice, they would say, Tim, you're just cherry-picking the literature. But again, I think there's a legitimate explanation why this perhaps is not a game-changer study. And even in oncology patients, I think we still have cause to be more conservative. So now let's talk about your bailiwick. Is cardiac surgery, is cardiology, is this a done deal? And the answer, again, after 17 years is still no. There still are some open questions, and I'm happy to address those. So one of the interesting things about my particular practice at St. Vincent is that we do a lot of cardiac surgery, and we do even more cardiology. We're one of the biggest cardiology centers in the nation. We do something like 15,000 PCIs a year and like 2,000 cabbages. So again, cardiology was as interested and invested in conservative practice as basically cardiac surgery at our hospital. And so the thought certainly was maybe cardiac patients or patients with active cardiac disease, maybe this is the exception to the rule. Maybe this is the patient population that needs more blood because, you'd think if somebody is having ischemia, unstable angina, or having an MI, this is the patient population that really needs more blood. The problem is that evidence hasn't really borne out that way, and the early evidence was not prospective randomized trials. It was simply retrospective reviews of large FDA databases looking at PCI patients, where they tried to balance patients using propensity analysis, looking at the difference between transfused and non-transfused patients with acute MIs or unstable angina, statistically balanced. The interesting thing about these early studies, and this was a large review published in 2013, is the findings were very surprising to most cardiologists, because at least what the retrospective review said is if a patient comes in with a heart attack or unstable angina and they're transfused, they don't get better, they get substantially worse. They have more MIs, they have higher mortality, they have more complications all the way around. And again, if you think about blood physiology, and we'll talk a little bit about it, but I know you know that, most cardiologists, like most physicians, thought that blood was magical and instantly delivered oxygen to the tissues in a very clean way. Now we know that blood from the blood bank is a pro-inflammatory, pro-coagulant nightmare. When we transfuse patients, we give them a pro-inflammatory, pro-coagulant. We also add burden to their heart from a cardiovascular standpoint, give them some volume overload, and these things are not likely to offset the potential benefits of increasing oxygen carrying capacity. So at least the early look-back studies from the cardiology literature suggested and still suggest that perhaps even in patients with active cardiac disease that transfusions may not be the answer. Of course, the best answer, as I'll keep saying, is neither being anemic or being transfused. That's the best possible outcome. So we're still waiting for the final prospective randomized trial and cardiology study. I've talked about GI bleed patients. I've talked about orthopedic patients. I've talked about pediatric patients. We still don't have a large prospective randomized trials in cardiology patients. The only thing we have is a pilot trial, and pilot trials are by design, they're just kind of, they're like a business plan for investors. This is what they are. They essentially are small trials trying to get larger monies from the NIH or somebody to do studies. So there is published a pilot trial looking to do a larger trial called the MINT trial, and again, unfortunately, at least from my standpoint, when the study was published, there was a suggestion that patients who with active cardiac disease do worse being transfused more conservatively versus liberal. But again, there's some asterisks associated with this particular pilot trial. Starting with, there were only 100 patients enrolled. Once again, because it was a small study, it was not a balanced group. The patients were sicker in the conservative arm. There just weren't enough patients enrolled. And as the authors readily admit, although there is some pause for concern here, until we do the large 1,000-patient study, we still are kind of asking, what is the answer in terms of cardiology? And then finally, let's talk about cardiac surgery. So cardiology, still an open question. I'll give you my opinion in about 2 slides. In cardiac surgery, again, are there open questions? The answer is yes or no. I mentioned one study that was published, which was called the TRAX trial, published in 2010, prospective randomized study in cardiac surgery patients perioperatively transfused at a hemoglobin of 8, no difference in outcomes, at least equivalent. This study, called the TITRE study, published out of the UK, was largely looking to replicate this in a multi-institution fashion. So again, here we have a 7.5 versus 9 trial. Nobody is standardizing this. It's not 8 versus 10. It's not 7 versus 9. It was a 7.5 versus 9 trial. Very good study in terms of the controls that were used, very large number of patients populated, primary outcomes and secondary outcomes of interest. Primary outcomes, as you can see, serious infection, ischemic event. Secondary outcomes, all the other bad stuff that happens in cardiac surgery. The conclusions of this study is all primary outcomes were equal. Similar to the TRACS trial, no difference in primary outcomes between 7.5 and 9. No difference in all of the secondary outcomes, 7.5 versus 9, except for one of the primary or the secondary outcomes, which was mortality at 90 days, which favored and tripped over the line with a p-value of 0.045, favoring the more conservative group. So here we have a study that, again, for the most part, seems to validate a conservative approach with an asterisk is perhaps in a subgroup of patients at long-term mortality, there may be some pause concern of a more conservative approach. But this is kind of the funny thing Bruce is an academician. He's got a laboratory with, paid PhDs. I'm just a plain old country anesthesiologist. I'm an incidental academician. But it's sort of funny to look at these studies, how two people can look at the exact same study and come up with different conclusions. So I highlight this. The author who published this, and understand, you don't get published in the New England Journal of Medicine for a Me Too study that says, well, we found what everybody else found. You better find something different, and you better pump up the volume and say, this is a groundbreaking study that really changes our entire approach. And that was basically the approach of the author, who said, the results of our secondary analysis create new uncertainty regarding a restrictive approach to cardiac surgery, which is a pretty bold statement, but it's designed specifically to get this thing published. What I think was good, and it's a rarity, is the editor, the editor of the New England Journal, actually differed with the author, even though it was published in the New England Journal. And again, their conclusion was this, is despite the author's discussion and contention that this is a game-changing article, it simply supports, in our opinion, every other study that has been published since 1999, is that a conservative approach to transfusion cardiac surgery patients is at least as effective, with the possible exception of more long-term outcomes. So again, I wanted to make sure that I presented both the favorable approach to conservative therapy. There is some literature in the past year or so that questions it, but the questioning is not as aggressive as I think it could be. And for me, from my standpoint, I don't really think we need to change our practice based upon these particular studies. What I'll go back to, and then we'll get on to the back end of this talk, is what does the STS say? And again, this is pulled from the STS, and the STS, and I need to correct myself, it's not just the STS, it's also the Society of Cardiovascular Anesthesiologists and AMSECT all have their fingerprints on the STS guidelines that were published in 2007 and again in 2011. This is the exact language that Bruce Spiess probably helped to craft in terms of recommendations for transfusion guidelines from the STS. It's reasonable to transfuse below hemoglobin of 6. 7 is also probably a reasonable number for transfusing both intraoperatively and postoperatively cardiac surgery patients, with very few exceptions. I will tell you again, as a interesting aside, at least interesting to me, is I had to review this recently because I was an expert witness in a cardiac surgery case where there was postoperative blindness. So I've been an expert witness twice, once for a death for OB hemorrhage, once for a cardiac surgery patient who had blindness postoperatively. I don't advertise that I do this. I don't like to do this. It's a total pain in the ass. Both cases, by the way, were for the defendant, not the plaintiff. But my job was to educate the jury about conservative transfusion practice, why, although the public's perception, and unfortunately many physicians' perception, is blood is all good, can't hurt, might just help, why that is not true, and specifically to back up this cardiac surgeon to say the cardiac surgeon was following the best available evidence as well as the guidance from the Society of Thoracic Surgeons. And it was probably not the right thing to say to the cardiac surgeon on the evening of the trial that I said, gosh, I'm surprised I'm even here, because my understanding is if a patient wakes up blind, all you're doing is arguing on how many zeros are going to be at the end of the check. You're going to get sued, but maybe you can take a couple of zeros off the check. This surgeon actually won and prevailed, partially, I think, largely on the argument that transfusing would not have helped, as tragic as it was that this guy was blind post-operatively, and none of the facts of that case change it, but the jury bought, essentially, this argument that the surgeon was following the best available evidence and prevailed at least in one court for evidence-based transfusion practice. So that's it. So my opinion, which again has been my opinion for some time, is 7 is the new 10. Less is more, with the possible exception of cardiac disease. But what we carved out, we published our transfusion guidelines in July of 2001, and our guidelines were this: a hemoglobin of 7 in most patients. For patients with active cardiac disease, and that's not fixed CABGs, that's not fixed PCIs, patients with unstable angina or MI, a transfusion level of 8 is not unreasonable. And I think today, in spite of there are some kind of nipping at the bud for the numbers, I think they're still reasonable today. And I'll tell you, one, my 86-year-old mother or mother-in-law had a TAVR. This is what we stuck to. My 87-year-old dad a year ago had a GI bleed. This is the number we stuck to. So I will just tell you, my practice is my own conviction. I still think this is the best information that we have. So finally, just to wrap it up, I think this is, you can take your pack off a little bit. I just want to briefly go through the why before the how. And what I have found, for physicians, and I think it's the same for nurses, I think it's the same for juries, is if you just present evidence and you talk about levels of evidence in 1A versus 2B and prospective randomized, people's eyes just kind of glaze over. So they have to understand the why before the how. And so one of the things that I did for this jury is I gave them my best sort of lay interpretation of why blood, although it's magical and it saves lives, why blood is just not as effective as we thought it was. And so I'll give you maybe a little bit more scientific approach of the why before the how. So why doesn't blood improve outcomes? And I could probably stop here, and maybe I will stop here, but this is the basic explanation. Blood from the blood bank is nothing like the blood that is freely coursing around in your veins right now. And to use the parlance, this is, blood from the blood bank is non-GMO, non-free range, non-organic. It is not the same thing. And yet that is the public perception. Blood from the blood bank is exactly like the blood that's currently in your veins. Absolutely not true. And this, in a large nutshell, is the best explanation that I can present to you and anyone else. Magically, what I would tell you is in the operating room, when a surgeon would bleed my patient down from a hemoglobin of 9 to 7, I'd give him 2 units of blood, I'd run the hemoglobin again, it said 9 again. Magically, I presumed that those 2 units of blood that I just ran in were working exactly physiologically like the blood that was lost. Couldn't be further from the truth. And so what Bruce talked about a little bit is the blood storage lesion is simply an explanation to talk about why blood from the blood bank is not the same as blood that's in your veins. And there are a variety of things to support this, immunologic reasons, infectious reasons, etc. But again, physiologics, I think, is probably the strongest argument that we have. So again, a very busy slide. I won't go into great detail with this whatsoever, but this is an evolving knowledge to try to explain why blood from the blood bank is different. Again, very simplistically but very effectively, when your patient is on the operating room table, their blood is their own blood at 37 degrees centigrade, fully charged up with ADP, glucose, and all these other things. Blood from the blood bank is 4 degrees centigrade, sitting in a plastic bag in a refrigerator from anywhere between 10 to 20 days. They are simply not the same thing. And although ABO incompatibility is important so patients don't instantly die, the fact that that blood has been sitting in a blood bank refrigerator at 4 degrees centigrade substantially changes the property of that blood. And there are a variety of things that are being investigated. Most certainly, and probably most dramatically, is the rheology and the morphology of red cells changes very, very quickly. For red cells to maintain that very unique biconcave dish shape, They have to be at 37 degrees centigrade. They have to have glucose, ADP, all those other things. When you drop blood into that cold storage solutions, it can no longer maintain that unique shape. So red cells are illustrated on the left-hand side, become increasingly misshapen, increasingly abnormal looking, and increasingly inflexible. In fact, they start to look like sickle cell disease under a microscope. And that's kind of what we do when we transfuse cold blood. It's an iatrogenic sickle cell disease that we give back to these patients. And so there's no way that these red cells can physiologically do what they're supposed to, which is squeeze and deform to be able to get through the last capillary mile and squeeze themselves down from about 8 microns to 5 microns. So there's rheology issues that are very, very real when we store blood, and it happens very, very quickly because they're cold and they don't have the appropriate amount of nutrients to be able to do it. And then as Bruce talked about, and he could talk all day about this, blood is a bad actor because when we put blood into this cold storage solution, some of those red cells die every single day in the bag. And when they die, the breakdown products of that senescence have nowhere to go because we're not washing these cells every single day. We are simply letting these byproducts accumulate slowly in the bag. And the byproducts from this breakdown of red cells that happens unless you freeze them include pro-inflammatory cytokines, procoagulants such as little spicules and pieces of red cells, tumor necrosis factor, TNF, etc., all the things that Bruce talked about. And the longer we store blood, the more of these breakdown products accumulate in the bag. So what happens when our patients come in needing cardiac surgery or having a heart attack, although we would like to think we instantaneously, cleanly get oxygen carrying capacity, red cells do not have the morphologic ability or the physiologic ability to actually deliver oxygen to the tissues, and forget the 2,3-DPG thing. That's just kind of icing on the cake. But we're also dumping a lot of really bad things into the mix as well, these pro-inflammatory cytokines. And again, remember, breakdown products are very active procoagulants. Now, when blood first hit the streets in the 1920s with blood banking, actually bit of trivia here, the first blood bank in the United States was Cook County Blood Bank, and that was a game changer to be able to store blood. Most patients who got blood were not stable GI bleed patients or stable ICU patients. They were exsanguinating trauma patients, and giving a pro-inflammatory procoagulant to a bleeding patient, probably not that harmful. Most patients today, however, are not exsanguinating and bleeding. It is a decision individually made by that PA, physician, nurse practitioner that says, I think they need blood. And in these stable patients, that pro-inflammatory procoagulant leads to all the adverse effects that Bruce has nicely talked about as well. So again, we'll just go through the complete list. As Bruce mentioned, when patients come into the hospital, they're not concerned about the lack of morphology or these bystanders. They go, gosh, doc, I don't want to get HIV or hepatitis. But as Bruce mentioned, these are like 1 in 2 million. HIV at its peak was about 1 in 1,000. Hepatitis, believe it or not, was 1 in 100. These are now about 1 in 2 million. So it's not that they're non-issues, but these are less significant than they used to be. There's emerging threats. I think that Zika has the potential to be a potential game changer in terms of exposure to our patients as well, but that's not the real issue. The take-home point here that I think Bruce went through is that the clear and present danger for transfusions are not the non-infectious risks of blood, not the infectious risks, they are the so-called non-infectious serious hazards of transfusion, which none of you got in perfusion school, no nurse gets in nursing school, and no doctor gets in training. I have a senior medical student, he's never heard about any of the non-infectious risks of blood, but that's the clear and present danger to our patients. And things such as Trale and Taco, as Bruce talked about, these pulmonary complications, which may be as high as 1 in 20 patients, almost 5% of patients can get either Trale or Taco. That's the clear and present danger with very high morbidity and mortality. And just to give you some perspective, HIV is 1 in 2 million. Taco is arguably 1 in 20. Taco is 100,000 times more frequent than HIV or hepatitis, yet how many physicians, nurses, and patients could pick it up out of the lineup. They simply can't do it. So we need to do a good job of the why before the how of educating our physicians, nurse practitioners, PAs, as well as our patients that there are many other risks to be associated with transfusions. The non-infectious risks are the predominant ones, and again, as Bruce has done a great job talking about these have to be in our mix. Now, Bruce talked about trolley. I want to spend maybe 45 seconds about talking about TACO. My feeling is TACO is a much, much bigger issue than trolley. There's probably no pure trolley or TACO. There's probably some inflammatory component to all volume overload. There's probably some volume overload component to most lung injury. One of the things that Bruce talked about is, he was talking with his docs, and they're saying, well, I've never in my years of being a cardiac surgeon or cardiac anesthesiologist, I've never seen trolley. Well, this is the way that I talked to them, 10 years ago. I said, well, you've never seen trolley, but you've seen shock lung, pump lung, trauma lung, or the Vietnam era guys called this Da Nang lung. So we have seen pulmonary injury associated with transfusion for years, but we didn't figure that it was actually transfusions. In fact, it is transfusions. TACO, which is volume overload, is likely somewhere between 1 to 5% of all blood transfusions. And again, my main point on here, which I'll quickly get to, is that TACO is not only one of the most high morbidity, high frequency complications associated with transfusion, it's largely avoidable and iatrogenic. TACO is largely iatrogenic. So why do patients get volume overload? There are three main reasons. Doctors give blood to patients who don't need it. That's reason number one why we have so much TACO. Reason number two is you never give a single unit of blood. If you're going to give one, let's give two. And it's that second unit of blood that tips them over edge. And the third thing, which is very important when you look at this from a multidisciplinary standpoint, not only are physicians not trained to order blood products, nurses aren't trained to hang blood either. So nurses give blood way, way too fast because they get absolutely no guidance for the appropriate rates of administration. So again, my contention is not only is this one of the highest morbidity things we have, we really don't need to have it whatsoever if we educate physicians, nurses, as well as patients on this. Finally, I think the last really, really important point that I always talk about in terms of the why before the how is that transfusion harm is dose dependent. Transfusion harm is dose dependent. And what I was taught as a young surgery rotator and anesthesiologist is that transfusions were all or none. You're either transfused or you're not transfused. And what we were taught was to avoid transfusions as long as we could, but once you tripped over the line, it didn't really matter whether they got 1 unit of blood, 2 units of blood, or 5 units of blood. It's all or none. Absolutely not true. There are a variety of both medical and surgical studies that if you think about the physiology, this also makes sense. Each and every unit of blood causes incremental harm. Each and every unit of blood, whether it's 0 to 1, 1 to 2 to 2 to 3, each unit of blood causes incremental harm. And that's an incredibly important comment or concept because of what I will make my final comment. This is not about bloodless medicine. This is not about eliminating every single blood transfusion in every single patient. This is about giving patients no more or no less blood than they need. No more or no less blood than they need, whether it is a red cell, a plasma, or platelets. The concept actually is very, very simple. I would sum up this entire talk about blood transfusion therapy, evidence-based practice, and patient safety with this. We should give patients the minimum effective dose of blood products and no more. That is our goal. Not no transfusions, not all transfusions, but the least amount of blood based upon the best available evidence as well. So in summary, again, I'll just come back to a slide this one and then the comment that Bruce made. Before and after, I've been at this for a long time. I think it is kind of funny that there are certainly some things the same today as they were 20 years ago. We had a Clinton in the White House in 1996. Maybe in 2016 we'll get another one there. What is absolutely the same in 20 years is anemia is just as harmful today as it was in 1996. And I think that's another important thing to emphasize to your physicians. We're not saying that anemia isn't good. It's bad. And many of your techniques for preoperative preparation, lower pump prime volumes, blood recycling, wrap, all these things can also reduce the impact of anemia. But in addition to the fact that anemia remains harmful, transfusions are not the panacea that we viewed them to be 20 years ago. So we've gone from thinking that transfusion risks are infectious. Really, the issue is non-infectious risks of transfusions. We have gone from thinking transfusions can't hurt, might just help, can't hurt, so if we're going to give one, give two, to thinking about the minimum effective dose and single units in many cases. And again, moving from kind of 10-30 rule as the rule of thumb more to 7 as the new 10, perhaps 8 in patients who have active cardiac disease. So again, this just ties us back to Bruce's talk. And I'll come back to what is our best available evidence and our guidance. I'm not here saying that the only thing to do or the most important thing to do in cardiac surgery blood management is evidence-based guidelines. What I'm saying, it's a part of the process. If you are simply focusing on what you can do in the operating room as perfusionists, anesthesiologists, and surgeons, and you are ignoring what happens upstream and importantly downstream, your patient is not getting the benefit of the doubt. And a lot of my drive to change my personal practice, my system practice, and national practice has been my frustration that I illustrated with my mother-in-law. No matter what happens, if 4 out of 5 doctors say thumbs up for conservative practice, all it takes is one doctor or nurse practitioner or PA with a stroke of a pen or a click of a mouse that completely undo everything you do. All I'm saying is evidence-based practice in a systematic way has to be a component of comprehensive blood management cardiac surgery. So thank you very much.